bargaining with the province on a regular basis. If we do not do this in an imaginative way, we will have what Alex is saying here. I'm sorry you're a lawyer, that's why you got that treatment. And that is because we allow the private sector to do their thing governed by market forces. I sympathize with you when you have to pay 50 million for cataracts. Give me 50 million and I spend it on primary healthcare, and the outcome will be vastly different. In my first example, Dr. Gonzaga, who told me that, was really saying on outcome. I'm a doctor, I'm sympathetic to people who are very sick. But the reality is, how many cancers can you cure, even if you call them 1 million? This is a sick patient, requiring all kinds of care, in the end, he's dead. Dialysis, he will be lucky to be alive for 10 years because that dialysis will source of patient. In other words, while we sympathize with them, these are people needing help. But let us look at the bigger number of people for which a little money will go a long way in their health. So, unless you want to give me the whole day, I am going to stop at this point. So, one last thing. In the process of primary health care, because we are just completing this study supported by PHAP, we found that to have an effective primary health care, the primary health sector that has to be attended to are two. One is leadership and governance, and the other one is financing. They're really intertwined. Very difficult to dissect one from the other. What happens with the leadership and governance? If your mayor, Madam Secretary, if your mayor is just not interested in health, he's not going to put in any effort to put a barangay health worker or a barangay health station. So that's depending on his will. What we are suggesting at this point is the next president, among the presidents he will do is that he will say something like this: Mr. Secretary of Local Government and Mr. DOH Secretary, I am giving the Secretary of the DOH an oversight function in health over you. Therefore, the example is, if Mr. Mayor, you are not doing your job, DOH will come in. I will hire a municipal health officer, I will provide the venue, I will support them and deliver health care. The moment you feel that you can take over, I will give it to you back. So this one. The other one, last question. The way we are handling our funds is inefficient. We are suggesting that we pool our funds in health and the one coming to tax money. Why? Because our priority has to be constantly reviewed. Maybe this year I want 80% for primary health care or 20% for inpatient. I cannot do that if I am not empowered to handle the funds. I tell you, there will be more funds, but some funds may be included only in the sense of accounting. For example, you want the share of local government, you can attach that. But you can say, if you have a share, alisin na namin sa aming budget. Anyway, you are providing the services. What we will use the fund for is depends on our regular evaluation on what we need for this particular space time. And I think that's very doable. We have a lot of money to do everything. Thank you.
Well, we've heard from Dr. to the theme of primary health care. You know, and the concept of having every Filipino connected to one health professional who can navigate the system. I'm going to show this question to John and to Oscar, okay? And still on access. But since you look at access from a big picture, epidemiologically, and really from the point of view of how much resources we have, Oscar, I guess the question is looking forward within the next 6 years. What would be realistic parameters for patient access. We heard a presentation of Carlo that showed that in many places in the country, places are still very, very isolated. You have to work out arrangements. You have to improve public facilities. You have to cut deals with private sector. Now we're trying to widen access for everyone, not only those in the cities. So what would be the parameters for access if you think of it from a country point of view, taking into consideration urban and rural, taking into consideration socioeconomic class? What would be, you might say, attainable aspirations for access in the coming years?
In 5 seconds. Usually, if you as an epidemiologist a question, we would take a year and give an answer. But I think a quick answer would be, in order to provide access, you probably have to prioritize the services that you need to deliver. I looked at I remember the definition that you put in, ensure services that are needed. But to be able to give access to more people, you can't spread yourself too thin and try to provide all possible services. You have to look at criteria by which you can identify priority diseases, priority services. So, for example, one of the studies we did for PhilHealth, we found that 80% of the burden of diseases, 80% of the burden is accounted only by 48 diseases, and 40% of the burden is accounted for by only 10 diseases. So one approach would be to focus resources on a few key diseases and on the most cost-effective interventions. And then for government, probably that should be the priority. Use burden and cost effectiveness as criteria identifying what to provide.
Okay, Oscar?
I was preparing for the original question, but now I'm saddled with...
You can answer both.
So let me answer the second question personally, if I have the time and not with this. I answer the first question. One thing we haven't answered is we haven't undertaken a thorough evaluation of the evolution. There are 2,000 local health systems there. Provinces, municipalities, cities. I have gone to about half of them. And I tell you, there are excellent local health systems, there are middling local health systems, and there are simply mediocre and very bad local health systems. I would say, based on my experience, that probably 10% of them would be excellent. The remaining middle half would be middling, and the bottom third maybe are just hopeless. That's my guess. What we haven't done is do a thorough impact evaluation of what we have experienced over the past many years since 1992 when the evolution was undertaken. I haven't seen any rigorous effort to do so. And this is what I have been arguing since I came back to the Philippines in 2010, that we should do something like that. And we made an effort again to submit a proposal to an institution, and it was turned down for many reasons, that it's too expensive. Well, how much money are we pumping into these local health systems? And why should a 1 million evaluation or even a 5 million evaluation and evolution be considered expensive? What I'd like to do is to really do a thorough, honest to goodness, rigorous evaluation of what makes the evolution work and what makes the evolution not work in certain localities. Do we know the answer?